Hello, everybody. I'm so excited to be here talking to you today. Thank you so much for joining me talking about nutritional interventions for high cholesterol and cardiovascular disease. As Rohini said, my name is Dr. Sundhya Raman. I am a medical doctor and qualified in lifestyle medicine with the International Board of Lifestyle Medicine, as well as the British Society. And as mentioned, I do work as a lifestyle medicine doctor at a company I founded called My Wellness Doctor. I'm also the lifestyle medicine lead at the Primary Care Cardiovascular Society. I'm going to start out today just looking at where we are in terms of cardiovascular disease here in the United Kingdom and how lifestyle is important with regards to this, with a specific focus on cholesterol. How do we put prevention into practice? And in this case, I'm going to focus on a little project that I ran at a GP practice using lifestyle change to lower cholesterol. And then when we're talking to our patients, how can we emphasize the best foods that they should swap on their plates to have the highest impact? And of course, what is the role of fish in cardiovascular disease protection? And finally, how does nutritional intervention stack up against our typical medical management for cardiovascular disease? So to begin with, this graph here shows our cardiovascular mortality for the 4 countries of the United Kingdom over the past 40 years or so. And you can see that we've had a really significant downward trend for the 4 countries. And so year on year, we have been managing to drive down mortality, except over the last decade. And we've pretty much plateaued in those gains. And that small inset graph is one from the British Heart Foundation from earlier this year that shows that actually we're seeing a reversal of this trend. We're seeing an increase in premature mortality from cardiovascular disease. This graph here shows our top 10 causes of disability adjusted life years, also known as DALYs. Now, one DALY is every year of healthy life expectancy, which we lose to either being sick from a disease or dying prematurely from a disease. So it combines these two metrics. And what you'll notice is right there at number 1 is ischemic heart disease. A little bit lower down is stroke. So cardiovascular disease is our number 1 cause of both death and disability. So we currently have, according to figures from the British Heart Foundation, as of 2024, we have about 7.6 million people in the UK with cardiovascular disease. 1 in 2 of us are predicted to develop cardiovascular disease over our lifetimes. 1 in 4 of us are predicted to die of a cardiovascular cause, and 1 in 6 of us are predicted to suffer a stroke over our lifetimes. And this is our number 1 cause of severe disability. And all of this is particularly disheartening, given that this recent report from the King's Fund says that a staggering 90% of all cardiovascular disease is completely avoidable through managing our modifiable risk factors, largely our lifestyles. So is it just us who are doing particularly badly, just kind of plateauing, not really making gains? Well, this Public Health England commissioned report from 2020 had a look at how we're doing compared to similar socio-economic countries for a whole host of conditions, including heart disease. And this is the graph for heart disease. So along the bottom is the year, and along the side is the change in years of life lost, essentially premature mortality. And this is for heart disease. The graph on the left is for women, the graph on the right is for men. And the broken orange line on each graph is England. What you'll probably notice quite strikingly is that everybody is pretty much the same. Where they've plateaued may differ, but everybody has plateaued. Nobody is really driving down mortality from heart disease, except for one very, very striking outlier, which is Finland. We're going to come back to Finland a little bit later in this talk, so don't forget about Finland. Now, I've mentioned that 90% of all cardiovascular disease is completely preventable, but what is it that's really driving chronic disease and heart disease? Well, the Global Burden of Diseases study is the most extensive, comprehensive study on the causes of death and disability globally. It's broken down by region and it's broken down by country. And this is the data for the United Kingdom. So along the bottom are the percentage of DALYs, again, disability adjusted life years, that are attributable to the risk factors shown along the left. Now, both globally and in the United Kingdom, our poor diets have become the number one driver of chronic disease. They've overtaken tobacco. And the contribution of our dietary risks to cardiovascular disease is shown by that dark blue rectangle. It's really, really substantial. So, given that the vast majority of cardiovascular disease is preventable and that our dietary risks are the main driver contributing to most of cardiovascular disease, you would hope we'd have really clear, actionable guidelines that we can give to our patients on what constitutes a cardioprotective diet. And this is the information that NICE suggests we should be saying to our patients in order to protect them from cardiovascular disease. So, what they say is we should tell our patients to have a total fat intake that is 30% or less of their total energy intake. Saturated fats should be 7% or less of total energy intake. Now, of course, unless what our typical patient does every time they sit down at the dining table or sit down for a meal at a restaurant is they work out their caloric intake for the day or predict it, and then they look at each item of food on the table and they weigh it and then look at food charts to work out how much saturated fat is in there. Of course, nobody's really going to use this advice. It's really not practical advice. So for the next part of my talk, I'm going to explain why there's this complicated information around dietary fats, and then I'm going to go on and signpost you to some really fantastic international guidelines that would let any patient eyeball a plate wherever they are, whether they're in a restaurant or going in to prepare a meal in their kitchen, and it will say this is a cardioprotective plate. So first of all, let's start and have a look at why they have this information that's very confusing around dietary fats. Well, first of all, when it comes to our lifestyles, um, things like sleep and exercise, they don't affect our LDL cholesterol, which we commonly term our bad cholesterol. They really affect our HDL cholesterol, which we commonly call our good cholesterol. When it comes to our LDL cholesterol, our so-called bad cholesterol, it is our diet that is by far the biggest cause and the biggest cure. And there are three things in our diet that raise our LDL cholesterol. The first are trans fats, the second are saturated fats, and the third is cholesterol itself. Now, trans fats, probably most of us became aware of in the 80s and 90s when we had those hydrogenated vegetable oil margarines, which we thought were healthy, and then we realized they're really bad for us. They drive up our LDL, they lower our HDL, and they drive atherosclerosis. Now, in this country, we didn't ban trans fats. We asked the food sector to voluntarily remove them from our food. So they are still there in our industrially processed, ultra processed biscuits, cakes, donuts, pastries, and foods like this. They're also naturally found in red meat, poultry, and in dairy. And once upon a time, we weren't that certain whether these animal source trans fats were as harmful as the one from industrially processed, ultra processed foods. But the World Health Organization had a look at all of the research and they said it doesn't matter what the source of the trans fats are, they are equally damaging, they equally raise our lipids. And the National Academy of Sciences has said there is no safe lower limit on our intake of trans fats. All intake increases our risk of heart disease. Now, in practice, however toxic trans fats are, they are only in small amounts in these foods. By far, the biggest driver of our LDL cholesterol are saturated fats. They're in much higher amounts in these same foods, plus a couple of extras. So they're also found in eggs, as well as tropical oils. These are oils that are solid at room temperature, so palm oil and coconut oil. Now, since they started to reduce the trans fats, hydrogenated fats in foods, they've started to ramp up palm oil. So if your patient is plant-based and they have a raised cholesterol, ask them to look on nutritional labels to see if there's hidden palm fat in there, because that's often the case. Finally, cholesterol itself. It contributes the least to raising LDL cholesterol, but it's in the same foods. And about 15 to 25% of the population are what we call hyper-responders to dietary cholesterol. So this subgroup of patients really get the triple effect of not just the trans fats, the saturated fats, but the cholesterol as well in these foods. And this American Heart Association presidential advisory has said that reducing saturated fat in the diet reduces cardiovascular disease. Now, here we're talking about the end point, not the marker as in LDL cholesterol, but the actual outcome of cardiovascular disease by 30%, which is similar to the reduction achieved by taking a statin. Now, we can go beyond just reducing saturated fat in the diet, and we can add in cholesterol-lowering foods. And that was the approach taken by a man called David Jenkins in the United States, who created something called the portfolio diet, where he took a portfolio of foods, which are shown along the bottom, which each have known cholesterol-lowering effects. And his first study included 46 patients, which he randomized to one of three groups. Now, all three groups were put on a low saturated fat diet, so asked to reduce or eliminate the foods that were shown on the previous slide. Now, his control group were only on a low saturated fat diet. His first intervention group was asked to additionally take a low dose of statin, and his second intervention group was asked daily to consume the foods that are shown along the bottom. And what he did was, after 1 month, he repeated their lipids, and he found that the control group had reduced their LDL cholesterol by 8% within that month, and each of the intervention groups had reduced their LDL by 29 to 30%. There wasn't a significant difference between taking a low dose statin and daily consuming cholesterol lowering foods. And so here now are some really excellent international consensus statements that I would recommend you give to patients that really show them how they should be eating in order to provide the best cardio protection. So first of all, the European Society of Cardiology guidelines, number one in their healthy dietary characteristics is you should adopt a more plant and less animal-based food pattern. And the American Society for Preventative Cardiology says that the American College of Cardiology and the American Heart Association recommendations can be met with a Mediterranean, a DASH, which is the dietary approach to stop hypertension, it's a plant-based diet, a healthy vegetarian, and exclusively plant-based diets. Now let's take a slightly closer look at the relationship between cholesterol and cardiovascular disease. So this graph here is a summary of meta-analyses of three different types of trials. In red are randomized controlled trials. These are typically of statin drugs. In grey are prospective cohort studies, and in blue are Mendelian randomization studies. Now, our x-axis is our magnitude of exposure to a lower LDL cholesterol, and our y-axis is the proportional reduction in the risk of heart disease. And as you would expect, as you increase the exposure to a lower LDL cholesterol, you have greater protection from heart disease. And that's why the gradient of these lines is in that direction. But the thing I want to bring your attention to here is the gradient of these lines. And so the trials in red, the RCTs, have a median follow-up of 5 years. The prospective cohort trials have a median follow-up of 12 years. And the Mendelian randomization studies have a median follow-up of 52 years. And so what you'll notice is the longer the duration of the trial, the steeper the gradient of the line. And what that's telling us is that at any given lowering of LDL, the greater the duration of the trial, the greater the protection against cardiovascular disease. So it's not just how much we lower LDL by, but for how long we lower LDL that is protective. Now, the authors of that study went on to model several scenarios. So along the bottom is age, and our y-axis is the cumulative lifetime incidence of a major cardiovascular event. Now, although this was a sort of combination of a huge number of international studies, here in the UK, we typically initiate lipid lowering at age 62 years. So this line at the bottom is usual care. And so this, let's assume that we initiate lipid lowering at age 62, we sort of start to blunt that risk curve towards the end. Now, supposing we were to start a little earlier at age 55 and aim for 50% LDL reduction, you can see by starting just 7 years earlier, we significantly reduce the lifetime risk of ever having a major cardiovascular event. Now, supposing we were to start even earlier at age 40, but have a less ambitious target of 33% LDL reduction, we gain even more protection. There is a huge amount of protection. These lines are never ever going to meet. This dotted line at the bottom is a lifetime of lower LDL cholesterol. And what this tells us is that if you start early, you get greater protection and for less effort. And this was the concept that I was trying to leverage when I did a project with a GP practice, because what happens is we have the health check at age 40 and we identify risk with a raised cholesterol. But unlike with the diabetes prevention program, we don't really have anything in place to then mitigate that risk. That person carries on having an increased risk until they reach a threshold, and then we usually then start prescribing statins. So here, what we did was at this GP practice, we found people on their system through the GP records that had had a raised cholesterol on their health check, but didn't meet the threshold that we would usually. This is a calculation, the Q risk, that looks at their risk of having a cardiovascular event. They didn't meet the Q risk threshold at which we would typically think about starting statins. It was just a 6 session program focusing on nutrition primarily, as well as encouraging them to do exercise, improve their sleep, and manage their stress. And about a fifth of the participants were from a low socioeconomic area, from the bottom 25% in the country. And after the 6 sessions, we repeated their bloods, and this is what we found. 78% of them had lowered their total cholesterol by up to 28% and their LDL cholesterol by up to 38%. We also saw a fall in HbA1c there in the majority of them by up to 15%. And although weight was only repeated in 40% of the participants, because not all of the nurses at the practice were involved in the project, in everybody that we repeated weight, they had lost weight, up to 7.5 kilos in weight. This was without calorie restriction, without portion control. This was simply improving the quality of their diets. And most importantly, the people who were involved in this, all of them felt that the changes they made were sustainable and that their whole family had made changes. And this is really, really critical, because unlike medication that only benefits the person taking it, when we empower our patients to change their lifestyles, it has a ripple effect, not just on their families, but on their communities and potentially on society. And this is how we really stand a chance to turn the tide on this tsunami of chronic disease and cardiovascular disease. And of course, these same changes have a general health protection. These same changes protect us against type 2 diabetes, dementia, and many cancers. Now, one thing that often comes up when we're talking to patients is how to make the most effective food swaps. And I did speak about this study when I spoke to the patients on this project. So this study includes 6 prospective cohort studies, including over 29,500 participants who were followed up for up to 31 years. And what it looked at was replacing specific protein foods, animal source protein foods that are shown along the top here. And first of all, they looked at replacing it once a week with either other animal source protein foods or plant source protein foods. And what they found was that if you replaced 1 serving per week with the foods along the top, if you replaced eggs with, say, processed meat, you start to actually increase risk. But eggs, processed meat, and red meat replaced with red meat or poultry really didn't provide any protection. But if you did replace eggs and processed meat with once a week with a portion of fish, you did provide some protection. But fish didn't really provide any protection with replacing red meat or poultry once a week. And we did find that the plant foods provided more protection compared to even fish. If you were to replace the foods along the top daily, 1 serving daily, Again, eggs and processed meat really, it's a benefit even for replacing it with red meat, but also particularly with fish. But surprisingly, replacing red meat with poultry didn't provide any benefit, nor replacing red meat or poultry with fish. Again, the plant foods did provide more benefit. Finally, the authors pointed out that if you were to substitute multiple foods, this provided yet more benefit. So substituting two or more foods with the same number of foods was considerably more beneficial than single food substitution. So for example, if you replaced eggs, processed meat, and red meat with nuts, legumes, and whole grains, replacing one serving a week provided up to 8% protection from incident cardiovascular disease, 3 to 4 servings a week, up to 28% protection from developing cardiovascular disease. But daily pretty much halved your risk of developing cardiovascular disease. And this summary of meta-analyses really underlines it. So processed meats increase your risk of developing cardiovascular disease by 42%. Fish provides about 6% protection, whole grains 22% protection. And again, fish is outperformed by fruit, vegetables, nuts, and whole grains. So it's really important to underline to your patients how much they can protect their cardiovascular system by prioritizing those plants on their plate. The quality does matter, however. Now, this study, including 3 prospective cohort trials with over 200,000 participants who were followed up for up to 28 years and had no chronic diseases at baseline. So along the bottom is the plant-based diet index, and along the side is the hazard ratio of heart disease. You'll notice as you become more plant-based, you decrease your risk of heart disease. But when they divided this up into healthy and unhealthy plant-based foods, so healthy was whole foods, and unhealthy were things like sugar-sweetened beverages, refined carbohydrates, and fried potatoes. These start to increase your risk of cardiovascular disease. Here, along the bottom are our servings of food categories per day. And again, along our side is our hazard ratio for heart disease. Again, our healthy plant foods, each serving reduces our risk of heart disease. However, our less healthy plant foods, again, the same foods, refined carbohydrates, fried potatoes, and sugar-sweetened beverages, increase our risk along with animal foods. So what about fish? Well, although nutritional studies are obviously complicated, when you look at this study here, which was a summary of 4 prospective cohort trials, including over 190,000 participants, what they found was that there wasn't convincing evidence that fish protects against developing cardiovascular disease. However, it does protect against dying from cardiovascular disease. But even in this scenario, having 2 to 4 portions of oily fish a week is protective. Once you go above 5 portions, you start to increase mortality. And they think this is because of the state of our oceans, because of methyl mercury and the persistent organic pollutants that are bioaccumulating in the fish. And these start to increase our risk of developing disease and dying. So the maximum, so again, just to reiterate, there isn't convincing evidence that fish prevents cardiovascular disease, and at most recommend 2 to 4 portions a week if patients want to have fish. So what about compared to drug interventions for cardiovascular disease? Well, the PREDIMED trial was a primary prevention randomized controlled trial. So it included over 7,000 participants who were all considered at high risk of cardiovascular disease. So, for example, they had a raised BMI, they were smokers, they were diabetic or strong family history, things like this. And they were randomized to one of 3 groups, either the control group, who were given standard treatment and standard advice, and each of the intervention groups was asked to follow a Mediterranean diet. The first was asked to consume extra virgin olive oil each day, and the second intervention group was asked to consume about 30 grams of nuts a day. That's roughly a handful of nuts. And they had a composite outcome of MI, stroke, and cardiovascular death. And what they found was that each of the intervention groups had a 30% reduced risk compared to the control group of these adverse events. Now, the Leon Diet Heart Study was a secondary prevention randomized controlled trial that included over 600 participants who had had an MI but was now clinically stable. And they were randomized to one of two groups. The control group again was given standard advice and medical management. The intervention group was asked to follow again a Mediterranean style diet with the addition of alpha linolenic acid, which is an omega-3 fatty acid that's particularly high in foods such as walnuts, flaxseed, and soya. And they had three composite outcomes. The first was cardiac death and non-fatal MI. The second was everything in group 1, plus unstable angina, stroke, heart failure, and either peripheral or pulmonary emboli. And the third composite group was everything above, plus hospitalization for any cause. And again, their intervention group had significant protection compared to standard treatment, their control group, for all of these adverse outcomes. And when we compare that to this meta-analysis on statins for primary and secondary prevention, you can see that lifestyle, specifically food intervention, dietary intervention, has enormous protection compared to statins, at least on a par with, if not superior to. So it is absolutely not the poor cousin of medical management. And finally, what about Finland? Well, I'm going to tell you a little story about Finland and maybe why they're bucking the trend. So this beautiful forest and lake-filled province is North Karelia on the eastern border of Finland, just on the border with Russia. And in the 1970s, this area had the unfortunate distinction of having the highest cardiovascular mortality rate in the entire world. Men typically died in their 40s and 50s of heart attacks. Now, why was this? Well, after the Second World War, this quite poor rural community suddenly had a lot more money and they developed a dairy industry. So foods that had previously been quite rare became really prevalent in their diet, and it was killing them. Now, things like statins, drugs like statins didn't exist at this time. So they had no choice but to tackle risk factors, and that's what they did. So they began an enormous public health campaign that was essentially to follow what the European Society of Cardiology guidelines say, to adopt a more plant and less animal-based food pattern. So they had a grassroots and top-down campaign. They taught people how to cook. They had longevity parties. They even persuaded some farmers to grow berries rather than have animal agriculture. And they also began smoking cessation groups. And this is what happened. In 1972, 51% of men were smokers in the region. This fell to 36% by 2012. In 1972, 90% of households used butter, and this fell to less than 10% by 2012. And this is what happened in the region. There was an 84% decline in cardiovascular mortality in North Karelia. The initiative was so successful, they rolled it out to the entire country within 2 years, and all of Finland saw an 82% decline in cardiovascular mortality. Of note, 25% of this decline was down to smoking cessation, 75% was down to cholesterol lowering. Of that cholesterol lowering, 10% was down to statin use, which came in later in the 1980s. 90% was down to dietary change. There has never previously or since been such a focus on risk factor management. And perhaps looking at this graph, it is about time there was. Thank you very much. Here are some really, really fantastic resources that are well worth having a look at. Of course, there are the excellent plant-based health professionals fact sheets. They're on a huge range of topics, but specifically with regards to cardiovascular disease, there's one on cholesterol, there's one on cardiovascular disease, there's one on hypertension, there's one on stroke, and you can direct your patients to these. There's also the 21-day plant-based challenge with emails, resources, and support for your patients, for yourself, for anybody that you're concerned about with cardiovascular disease. and the very, very wonderful Daisy and Claire, who have a podcast called In a Nutshell on, they've spoken to so many people, and they are so fantastic at, raising questions, having a great conversation. And I had the wonderful honor of doing a podcast with them, and that's on cholesterol, and you're very, very welcome to have a listen to that. And a lot of people have told me they've passed this on to patients, and patients have told me that it's really, really helpful. So please do have a listen if you haven't. Thank you very much. So I'll stop sharing.
Let me just remove.
Sorry, just going to stop sharing.
Perfect.
Yeah.
Thank you, Sundhya. Incredibly informative. Do you have a glass of water you're
I
taking?
have got a glass of water. Thank
And
you.
we've got some really good questions in. So I'm going to dive straight in. You've given us some amazing talks before on diabetes and on other metabolic health issues. I'd love if you could share a little bit of background about this and kind of your personal journey as well, and kind of what inspired you to raise awareness of these issues and kind of get into lifestyle medicine.
Thank you. Thanks, Rohini. I'm not emotional. I'm just coughing. Sorry. So yeah, absolutely. Well, my lifestyle medicine journey was kind of accidental, really. So I was taking a career break with my second child. As you well know, Rohini, having two doctors in the family can make family life a bit tricky. So I thought I'll take a little pause, and suddenly I was very, very available to my huge extended family who all have diabetes, cardiovascular disease. I mean, it's a big problem for everybody, but it's a real South Asian problem. And I really felt that despite optimum medical management, I couldn't understand at that point why my family were suffering so much with this. So my dad in particular, he was diabetic since he was in his 40s. By the time he was in his 50s, he ended up needing quadruple bypass surgery at Harefield. I mean, amazing care. We're really, really privileged to have this care, but ultimately it really changes quality of life. By his 60s, more stents into those bypass grafted vessels, and he was blind by his 70s. So, you know, really lost his independence. And, my mum became his carer, and he sadly died of heart failure a couple of years ago. And my uncle came, and he was diabetic for 12 years, showing signs of eye damage and kidney damage. And then I went back to the research, and I thought, surely, they don't eat ultra processed food, they cook from scratch, they are active, they tend not to be overweight or obese, you know, moderate alcohol at most, if any. Why has it gone so wrong? And then we made these lifestyle changes, and it was, they were already vegetarian. It was when we cut out dairy that we saw a massive fall in HbA1c, reversal of the kidney damage and the eye damage. And so, you know, then I found out about the diploma, and this has been my path, and I've never looked back. It's been fantastic, really. Oh, I can't hear you, Rohini.
Thank you so much for sharing that. I think that story and your personal experience with your family members will resonate with so many people on this call and hopefully inspire them as well. Lots of amazing comments about your presentation as well. So lots and lots of questions. I'm going to try my best to get through all of them. And one of the top questions that we get at Plant-Based Health Professionals UK is we obviously talk about the benefits of a whole food plant-based diet, prevention, management, and treatment of so many common chronic health conditions, including cardiovascular disease. We do, however, still get inquiries from people who are vegans and who say, occasionally they might say, I'm vegan, but I've got high cholesterol. What other things to do in that situation? Why might someone who is vegan have high cholesterol, and what are the things that they should take into account?
Okay, that, absolutely. I get people coming to me for this as well. So one is something that I mentioned there around the palm oil and the coconut oil. So it has, particularly palm oil, palm fat has become really omnipresent, and it's even in stock cubes. So, you know, it's been added back in there just for that palatability, in so many cases. So if you are vegan with a raised cholesterol, one thing to look out for are those hidden fats. And also, if you're not eating these hidden fats, you may well be adding coconut milk to your Thai green curry. And, you know, this is essentially where we often make the mistake of adding in these things to our cooking, particularly when we have a risk of developing cardiovascular disease. This is something which we absolutely should keep an eye on. Other reasons, so could be genetic. So there are three types of genetic risk. I don't know if you want me to go into this right now, but
A lot of the questions that I'm getting are about familial hypercholesterolemia, and I think going into these in a bit more detail is super helpful for everyone on the call.
okay, fantastic. So when I mentioned three types of genetic risk, the first of these genetic risks is a mutation in a gene. It's what we call a true genetic risk, where essentially this means that the protein that it codes for doesn't really work. And when it comes to cardiovascular disease, by far the most common true genetic risk is exactly as you say, familial hypercholesterolemia. This is usually due to a mutation of the LDL receptor. Now, if you were to inherit two copies of that gene, that happens about 1 in 1 million, right? And it would have happened from very early on in life. So this is a much less common. It would have impacted you probably from childhood. More common is inheriting one copy of this gene, and that has an incidence of about 1 in 250. And so if you have, you know, a very strong family history of early onset, so, you know, by the 40s, cardiovascular disease, you should go see your GP and get tested for familial hypercholesterolemia. Now, the second type of genetic risk is something called polygenic risk. This is where there are about 60 known genes that are variants. So these are called single nucleotide polymorphisms. This is where the gene isn't mutated, it's just slightly different. And that means that the protein that it codes for may fold a bit differently or interact with the receptor maybe less effectively. So what that means is that each of these variants in the gene slightly increase your risk of developing cardiovascular disease. And this type of genetic risk, there was a study where they looked at people and they did this polygenic risk analysis. And they found that if you had a good lifestyle, even if you were in the highest quintile of this type of genetic risk, you pretty much halved your risk of developing cardiovascular disease. So even where you inherit a lot of these variants, you can substantially decrease your risk of developing cardiovascular disease by having a healthy diet, by exercising regularly, by not smoking, by not drinking excessively. Just those four things will pretty much halve that risk. The third type and final type of genetic risk is epigenetic risk. This is where, I mean, often so much of what looks like genetic risk is actually just epigenetic risk. This is where our DNA is unchanged, but we have tags on our DNA that switch our genes on and off. We do inherit those tags from our parents, our grandparents, even our great grandparents. So this is why it can look genetic, but those tags are malleable through our behaviors. So even if something looks like it runs in your family, it may not. It may simply be that you've inherited the way the genes have been switched on and off, and that by adopting a better lifestyle, you can reshape what looks like true genetic risk, but that isn't hardwired into your DNA. So that was the other thing.
That is so helpful, and I think very reassuring to lots of people who are dialed in. And so lots of different questions about kind of specific medical situations, and I'm really sorry, but we're not going to be able to answer those because it's very difficult and unethical to do so without knowing kind of all the full kind of background. One of the questions about testing is, what should total cholesterol and LDL cholesterol be after someone has had a heart attack?
Okay, so after a heart attack, you aim for a 50% lowering. Now, if somebody is, so actually the lower the better. We know that atherosclerosis stops completely at an LDL of 1.6. And if you get it lower, you can see reversal of atherosclerotic disease. So what one way of doing this is statin use, but in the studies, you've had to really, really ramp up statin use, and people suffer a lot with side effects of the medication. Another way, which has been shown by very famously by Caldwell Esselstyn and Dean Ornish. And this is really, really dramatic, where they show regression of atherosclerotic plaque with angiograms by adopting whole food plant-based diet, in the case of Caldwell Esselstyn, with no fat. So it's an oil-free diet that's whole food plant-based. But even things like, it's very, very strict in the sense that even high fat foods like avocados and nuts are restricted in that diet. With Dean Ornish, he had a whole food plant-based diet as the nutritional aspect, but they also increased exercise. They had group support and stress management as well. And both of these interventions, they showed a regression of atherosclerotic plaque. In the case of Caldwell Esselstyn, with people who'd had previous MIs, who had such extensive disease that they weren't deemed suitable for bypass grafting, because it was so extensive there was nowhere to attach a bypass graft. So even in very, very advanced disease, this has been shown to reverse cardiovascular disease and really dramatically lower adverse events, so heart attacks, hospitalization, even symptoms. So, no matter what, it had an enormous impact on quality of life of the patients, as well as reversing disease.
What is the consensus on eating nuts, seeds, avocados? What are your thoughts on it as a physician, but also what does the evidence show, and what are most kind of cardiologists on board with now?
So absolutely increasing. So when you look at the portfolio diet, so nuts, seeds, these kinds of fats, when you look at the American Heart Association guidelines, they recommend polyunsaturated fats. So absolutely recommend nuts, seeds, flax seeds, particularly avocados. I think these are really positive foods to have on board. They're satiating, they are full of healthy fats, they're full of fiber. Absolutely recommend them as a cardioprotective diet, as part of a cardioprotective diet.
And what are your thoughts within that about oils like rapeseed oil, olive oil? Obviously, there's a difference between different oils. We already touched on the fact that coconut products are very high in saturated fat,
Yeah,
coconut oil and coconut milk and coconut cream and these things, which often are in vegan baked goods. And Arvin from our membership pointed out that sometimes you find palm oil in supermarket breads and things like that as well. So yes,
absolutely.
we can. What are your thoughts on free oils, so oils that you might find?
So for me, I'm not oil free. I certainly have, I cook with olive oil, and I use extra virgin olive oil regularly on salads and things like this. And certainly from the Predimed trial, they found that extra virgin olive oil seemed to provide some cardiovascular protection. I think that it's potentially a slightly different approach if you have established cardiovascular disease, and maybe there's evidence that you should avoid added oils to your food. So those that are already intrinsic within the food, don't worry about, but having added oils maybe is something you might want to minimize or remove. But I certainly recommend to people that they cook with either rapeseed oil or olive oil. And certainly I have kids and they have a high fiber diet, and I don't want to remove calories from their diet either. So yeah.
Thank you so much for sharing that. And Claire, our wonderful education lead and IBLM lead, has been pasting some links to our free fact sheets on things like stroke, hypertension. And Claire, if you'd be able to share some of Dr. Shireen Kassam, the founder of PVHP, her articles on oil. It's recently been updated. I think there's a lot of nuance, and looking at the evidence there is really important. Obviously, oils can be very calorie dense, and for those who are trying to manage their weight, then including more of the whole food sources like walnuts and things might be good if you find that you kind of slosh a lot of oil on the pan or on the plate. It can be easy to do that. So I'm keeping the questions coming because we've got a lot of them, but there's a great question which is about plant sterols, and this is a big topic, but are the ones that are found naturally in foods, and perhaps you could share what foods you find these plant sterols in, or do you recommend supplements? And if it's the latter, which ones do you recommend for those who don't want to use things like plant-based spreads and things like that?
Yeah, so plant sterols and stanols are the plant version of cholesterol. So we make all the cholesterol we need. We make about 1 gram of cholesterol a day. We have no dietary need for cholesterol. Cholesterol is important for making things like vitamin D and our sex hormones. So we need cholesterol. We don't need to consume cholesterol to get cholesterol. And we pretty much recycle all the cholesterol we produce in our gut. So we recycle it in our small bowel. We reabsorb most of it. So when we have sterols and stanols, they are the plant version of cholesterol, and they compete at those cholesterol receptors in our small bowel, and they stop us reabsorbing it. And that's how they lower our cholesterol. So all plants have sterols and stanols naturally, but when you get these spreads and so on, they just concentrate it. So they're much, much higher. Um, and we do know that they have a cholesterol lowering effect. I, I don't take any supplements of this. I wouldn't know which ones really to recommend. I don't know if you do, Rohini, have a particular recommendation. Certainly when it comes to spreads, I tend to say Flora Proactive over the Benecol spread, simply because that one has milk in it. And I kind of think, well, you're adding a saturated fat and then adding a plant sterol stanol. So why, have both of these there? Whereas the Flora Proactive one is completely plant-based. But I don't know if you have a recommendation around
I was going to
supplements.
do the same as that, because obviously the other one isn't fully plant-based.
Yeah.
But if anyone has any tips, then please do share in our chat. Is it true that cholesterol hyper responders shouldn't take plant sterols? And if that's the case, how do you identify those people? There are things like phytosterol testing. Have you heard of that? Have you referred anyone for this? Do you know about this in particular?
No, so sorry. The question was, should they avoid
Taking
hyper
additional
responders to
plant sterols?
dietary cholesterol, avoid plant sterols?
Yes.
No, I haven't heard about this, so I'm really sorry. I wouldn't be able to give you advice on that specifically or shed
It's quite
great light on that.
quite specific. There are lots of questions about kind of the genetic tests and things like that. Who is the best person to see in that situation? Is it something that you recommend seeing a cardiologist straight away if you're concerned about that? What is the kind of the best way if you're in the UK?
So things like, so if you have a strong family history or of very early onset cardio, or in the 40s, cardiovascular disease, or you yourself have a very high cholesterol, maybe around sort of 7, then go to your GP, because you should be tested for familial hypercholesterolemia. The other polygenic tests are impossible pretty much to get on the NHS. You would have to have those done privately. But I would always say it's best to go via your GP if you're worried about familial hypercholesterolemia. So you're kept within the system, you know that you're definitely going to be followed up, people are keeping an eye on things, and you should then be on statin medication for that. So, but the polygenic test, and certainly there's no epigenetic testing, that doesn't exist yet.
And there are so many tests out there. I know there's a few that have come up in the chat and ones that I've heard of as well, things like testing your LPA, LP little a, and ApoB, which I don't believe that ApoB is offered on the NHS currently. What are your thoughts? Because every place seems to do it differently, and in the US some of these tests are a little bit more commonplace through insurance and things. For us in the UK and for people, what do you think of these tests? Are there any that you would say are really a gold standard apart from what's offered in a full lipid panel on the NHS?
So LP little a is a small little lipoprotein that you either, it's a genetically inherited one. Your level is genetic, and currently there is nothing, there's no medical intervention for that. And so you could have it tested and maybe you'll make lifestyle changes. It's not available on the NHS, but you can get it done privately. Um, However, that said, I was at the European Society of Cardiology conference a couple of days ago, and there is stuff in the pipeline for treating LP little a, so that there is a hope that it will become more widely available. But at the moment, there's nothing people can really do about it except manage all their other risks. So next one was ApoB. So ApoB is a protein that's on every single lipoprotein that could potentially lay down fat in your blood vessels. So it's on LDL cholesterol, it's on LDL, IDL, which is intermediate density lipoprotein, VLDL, very low density lipoprotein. But so all of these are lipoproteins, so proteins carrying cholesterol that could lay down that cholesterol in your blood vessels. And each one of them has one molecule of ApoB on it. So it tells you the full number and range rather than just looking at LDL. But 90% of those particles are LDL. So knowing your non-HDL and your LDL is great. It's not that inferior to knowing your ApoB, but ApoB has come out from the studies as being slightly better, and it's often used in the States. And it may be that over time we move to it here, but at the moment you're not being that shortchanged having your lipid panel as we have it now. I think the other one is high sensitivity CRP, which CRP is a very general inflammatory marker, and high sensitivity CRP measures that same CRP protein, C-reactive protein, but it's just a really sensitive way of measuring it. And on balance, the studies suggest that if you don't already know you have cardiovascular disease, it doesn't really show much predictive value. It's not that useful a test. It's not that discriminating. If you do have cardiovascular disease, there was a study recently in the London University hospitals, and it found that after patients had had a heart attack, if you looked at their troponin level, which is what we usually test to see if somebody has had damage to the cells of their heart, and you looked at the rate at which that rose, or you measured the high sensitivity CRP, high sensitivity CRP was superior to the rate of rise of a troponin in predicting another event. So it's a useful discriminator where somebody is at high risk or has had a cardiovascular event, but not if they haven't.
Super helpful, thank you. Okay, before we wrap up, I'm just going to launch a quick poll. I'd be very grateful if everyone could fill that in. And there was a lovely question here from a GP who said, loved seeing the primary care intervention. Has it since been repeated in your practice or expanded? Just wondering about the appetite within the NHS to focus on lifestyle changes and managing risk factors in a targeted way.
So interestingly, I mean, there was two primary care networks that were really keen for us to expand this, and we applied for funding from the British Heart Foundation. We didn't get it, but I've recently been approached by Kidney Research UK, who said, you know, maybe we could add in some urinary ACR, and we're looking now at expanding this with Kidney Research UK. So it's in very, very early stages, but yes, I think there is some appetite. I think things move very, very slowly in the NHS. So let's see. I hope so.
Yeah, that would be wonderful. And there was another GP, I believe, who was sort of saying, why do we as GPs wait until the Q risk is over 10%? I personally don't follow this. This is a person who's written, and I often start statins sooner for patients who are at high risk and have a strong family history or genetic history. Of course, lifestyle factors should be paramount, but should we be using lifetime risk factors like JB3 rather than 10-year risk factors in younger patients?
It's really interesting. So absolutely. So there's Q lifetime, which you can use for younger patients. I actually was part of writing JBS4, which we are hoping will come out next year. It's been held for a long time, and part of it is because they are looking at developing an algorithm that provides a more personalized risk score. But this is kind of a long and complicated kind of situation. And absolutely, I think that the only thing I would say with starting statins earlier is it changes the identity of the patient as somebody who goes from being healthy to having a lifelong medication. And that's why I think when we can see that lifestyle change is not just as effective in terms of lowering LDL cholesterol, but more effective in reducing adverse outcomes compared to initiating medication. It is never too early to start that conversation around lifestyle change because it has, as I mentioned, the same lifestyle changes reduce your risk of diabetes, cardiovascular disease, dementia, for which we have no truly effective treatment, but we know is so primarily lifestyle driven, and so many cancers. So we, exactly as you say, by the time we start statins in patients, 50% of patients within 2 years haven't reached targets. We're really firefighting by that point. So if we, after having a health check, or if we notice a raised cholesterol, we can say, you know what, the European Society of Cardiology guidelines say, if you prioritize those plants on your plate and send them to plant-based health professionals where they can get that kind of support, this is how you would begin that journey, with this 21-day plant-based eating challenge, or here are some fact sheets made by, healthcare professionals that you can look at and see whether you're doing the right thing. I think that this is really helpful, and I think people feel more empowered. It doesn't change their identity from somebody who's healthy to someone with a chronic disease or high risk of a chronic disease. It just makes them feel more empowered. um I think that, yes, I think that we should intervene earlier, but I do think it's with lifestyle change.
Thank you so much, Sundhya. And to everyone who wants to hear more, please do listen to Sundhya's episode on In a Nutshell on our podcast. It's absolutely brilliant and goes into so much detail. And do check out the link that Claire has just shared to our 21-day plant-based challenge. It's totally free, packed with recipes, informative tips from a dietitian. It's so helpful for everyone who's now understood the why. This is going to give you the how-to, and that's what we're all about at PBHP. And welcome again to the 35 new IBLM participants or diploma lifestyle aspiring physicians and professionals who are going to be taking their diploma later on this year. The deadline for this year has now closed, but if you are interested in signing up for the lifestyle medicine diploma for next year, then please email Claire at pbhp.uk, because we are already kind of registering interest for that. So and for those who are coming on Monday, we'll see you on Monday. Both Sundhya and I will be there. The conference is now sold out, but we still have lots of tickets for our November conference, which is virtual, so you can join it from absolutely anywhere from the comfort of your home. So I hope you will be joining us for an amazing day in November if you cannot make Monday's session. Thanks a lot, everyone, and
Thank
good
you
night.
so much.